we want to try and be specific to our assessment. I mentioned this earlier on with our clinical targets, but a lot of pelvic floor muscle training programs previously have used kind of blanket rules, aim for 10 contractions where you hold for 10 seconds, or targeting 30-second holds 3 times a day. Without an assessment of the muscles, it's difficult to know how appropriate these interventions are. And so I think this is one of the real pillars of this ideal assessment that we've created. Is it's really important to, and it sounds obvious, but it's really important to assess the muscles. Meeting the muscles where they're at will enable us to prescribe an appropriate training program. And we do this in all areas of physio. You never prescribe someone more Nordics than they can tolerate, or more of a sustained multifidus hold than what they can actually hold for. It's about meeting the muscles and meeting the person and the patient where they're at, and using that as a framework and a baseline to build our training program around. It's obvious, I mentioned it before, but again, thinking about mechanisms which constrict the urethra, and really trying to avoid those, and trying to isolate that, maybe is a better way of saying it, from those mechanisms which are more anal and focus on anorectal constriction. We've talked a lot so far. We'll continue to talk a lot about the validity and value of transperineal ultrasound as a tool for measuring pelvic floor muscle anatomy and function. And I touched on this just before about, rather than thinking about a maximal program. So a lot of these programs which have been investigated in, have been used previously in the research, are focused on these kind of more maximal approaches. A lot of it founded on Arnold Kegel's principles from the late 1940s and early 1950s, which again may have a lot of value in a postpartum context, but in a post-prostatectomy incontinence, we know that these muscles have to act in a different way. These striated muscles have to begin to do the jobs of smooth muscles. So maximum voluntary contractions may not be sufficient in isolation, and that it's logical that ideas of motor learning and principles of exercise physiology are actually really important to underpin the way we prescribe, the way we assess, and the way we teach these exercises. Okay, and then following on from that, thinking more so about coordination. How well can the person contract within the context which is important to them? If they're having incontinence with coughing, if they can do a wonderful 30-second maximum hold, fantastic. But if they can't hold against the force of a cough and it leads to incontinence, then the importance of their ability to hold is diminished. We need to design a program which targets their deficits, like any kind of exercise physiology. We really want to try and focus on finding their symptoms and giving them muscle-based strategies to manage these.